On a cold winter morning in Europe, when the streets of Milan, Paris, Berlin, Madrid, London, Manchester, Birmingham, Liverpool, Leeds, Edinburgh, Glasgow, Aberdeen, and Dundee shimmered with frost and early sunlight, people began whispering about a sickness that felt stronger than the usual seasonal flu. Newspapers called it the superflu, a name born more from fear than science, yet powerful enough to unsettle families, offices, schools, and hospitals. Trains still ran between cities. Buses moved through narrow streets, cafes stayed open, and churches, mosques, synagogues, and temples welcomed quiet prayers. Yet behind every cough and tired smile was a shared concern that something unusual was moving quietly through communities across Europe, England, and Scotland. Doctors explained calmly that the superflu did not appear from nowhere. Like many influenza outbreaks, its roots lay in the constant evolution of viruses. Influenza viruses naturally change over time, sometimes mixing genetic material when humans, birds, and animals live close together. In parts of Europe and the UK, migratory birds arrived earlier than usual due to changing climates. Poultry farms worked under pressure during the winter season, and international travel was fully active again. Busy airports in London and Manchester, ports near Liverpool, and transport hubs in Glasgow and Edinburgh created ideal pathways for fast spread. What people called super was not mystery, but familiarity wearing a stronger form. The cause was simple yet complex at the same time: a mutated influenza virus spreading through droplets when people talked, laughed, coughed, or shared crowded indoor spaces. Underground trains in London, office towers in Birmingham, classrooms in Leeds, universities in Edinburgh, factories near Manchester, and shipyards around Glasgow all became places where transmission happened quickly. Severity differed from person to person. Many healthy adults experienced high fever, muscle pain, headache, sore throat, and deep exhaustion. For older adults, pregnant women, newborns, and people already living with asthma, heart disease, diabetes, or weak immunity, the illness could turn serious, sometimes leading to pneumonia or breathing difficulties. Hospitals from Paris to Rome, from London to Glasgow, felt the pressure. Emergency rooms filled faster. Nurses worked longer shifts and doctors postponed rest days. Yet there was also discipline and coordination. Treatment focused on early recognition, rest, fluids, fever control, and antiviral medicines when required. Modern antivirals helped reduce severity when given early, while oxygen therapy and careful monitoring saved lives in severe cases. Antibiotics were used only when secondary bacterial infections appeared, reinforcing responsible medical practice. Prevention soon became the strongest shield. Health authorities urged people to take seasonal flu vaccinations, which, even when not a perfect match, reduced serious illness and protected the most vulnerable. Simple habits returned to center stage: hand washing, covering coughs, wearing masks in crowded indoor places, staying home when sick, and improving ventilation in offices, schools, and homes. Employers in London's financial districts, Manchester's industrial zones, and Edinburgh's academic centres encouraged flexible schedules and remote work. Healthcare workers, transport staff, teachers, factory laborers, and delivery drivers were recognized as higher-risk professions, and extra protective measures were introduced for them. The World Health Organization played a steady guiding role, coordinating surveillance between countries, sharing real-time data, and issuing clear, evidence-based recommendations. European and UK health agencies worked closely with WHO to track viral changes, update treatment guidance, and fight panic. NGOs stepped forward at the community level. Volunteers delivered food and medicines to elderly people in Birmingham flats, supported migrants in Glasgow, helped homeless populations in London, and provided mental health counseling to families overwhelmed by fear and isolation. Integrated disease management became a living system rather than a slogan. Hospitals coordinated with local clinics, pharmacies, laboratories, and social services. Digital health records and outbreak dashboards helped identify clusters early in cities like Liverpool and Leeds. Telemedicine expanded rapidly, allowing patients in remote Scottish regions near Aberdeen and Dundee to consult doctors without traveling. Modern advances such as faster virus sequencing, improved vaccine research, and AI-assisted diagnostics reduced delays between detection and response. Age and sex influenced outcomes. Older adults faced higher risks, while children often recovered quickly but unknowingly spread the virus within families. Some reports showed men experiencing more severe symptoms, possibly due to immune response differences and lifestyle factors, while women often carried the emotional weight of caregiving at home and in healthcare settings. Nutrition gained attention as a quiet but powerful ally. Doctors encouraged balanced diets rich in fruits, vegetables, proteins, and warm fluids. In homes from Rome to London, traditional soups, herbal teas, garlic, ginger, Kent, and honey returned to kitchens not as miracles, but as comfort and support. Environment and region mattered greatly. Cold weather pushed people indoors, increasing spread. Polluted urban air worsened breathing problems, while cleaner rural areas saw milder cases but faced challenges of healthcare access. Countries and cities with strong public health systems and community trust recovered faster, proving that long-term investment in health saves lives before crises even begin. Meditation, faith, and inner calm quietly supported recovery. In London churches, Scottish kirks, mosques in Birmingham, and temples in Europe, people prayed for healing and patience. Mindfulness, breathing exercises, and simple reflection helped reduce anxiety and support mental health. Religion and spirituality did not replace medicine, but they gave strength, hope, and unity. At the same time, authorities and doctors worked tirelessly to counter superstition and misinformation spreading online, gently guiding people back to science and compassion. Animals also played a role in understanding the outbreak. Veterinary surveillance increased across farms and wildlife centers, especially where birds and livestock interacted closely with humans. The One Health approach, connecting human-animal, and environmental health became more visible and respected, reminding societies that health is shared across species. As winter slowly loosened its grip, hospital admissions declined. Streets in Edinburgh and Paris grew livelier. Cafes in London filled again, and laughter returned to homes in Glasgow and Madrid. The superflu did not vanish overnight, but fear faded as knowledge and cooperation grew stronger. What remained was a lesson written quietly into daily life. Preparedness matters, kindness matters, and trust in science matters. In a small London flat, an elderly woman recovered with help from a young volunteer. In Glasgow, a nurse finally rested after weeks of service. In Manchester, a factory worker returned to work with gratitude. Across Europe, England, and Scotland, the superflu became more than an outbreak. It became a story of resilience. And in that shared recovery, people understood that even when new diseases appear, humanity's greatest strength is its ability to unite, care, and hope for a healthier tomorrow.